Dear colleagues, welcome to the second part of a two-part series entitled The Fall and Rise of Measles. With us today we have Dr. Tanya Melillo-Fenek, the head of the Infectious Disease and Control Unit. First of all, thank you very much for accepting to do this session with us, Dr. Fenek.
You're welcome.
On to my very first question, Dr. Melillo-Fenek. You are responsible for disease surveillance. Apart from this having an important role for statistic and epidemiology purposes, why is this important from the public health perspective?
The importance is related to spread of disease. Our remit is that we try and minimize as much as possible the spread of infectious diseases. So that is where we try and focus mainly.
Now turning our discussion to measles, because this episode is dedicated for measles, and as we all know, unfortunately there has been another rise in the cases of measles. How important is early recognition of suspected cases, especially given a scenario where most healthcare professionals, including those who have been practicing for quite some time, have either never seen a case of measles or haven't seen a cases in a very long time?
Yes, in fact, unfortunately, in all of Europe, we have seen a rise in measles where we thought it would have been eliminated by now because there is a very good and effective vaccines. But unfortunately, we know there are pockets of certain age groups where they never took the vaccine. And it happened now in Malta that this year we've had already over 29 confirmed cases. So it is very important that doctors are kept up to date, and that is our role in IDCU to keep doctors informed through information leaflets, so they are aware what is happening in the community. So when a person presents with a rash, they can consider measles as part of their differential diagnosis. I mean, from what we have seen, mainly we are seeing measles mostly in males between the ages of 25 and 45. These who wouldn't have had the vaccine when they were young. We have had a few cases in children who were still too young as yet to start taking the vaccination of the MMR or had just taken one dose. So for us, this quicker one case is picked up for nothing else because it has a very high infectivity rate. So one person, once is in the infectious phase, can infect a lot of people. And since a lot of these people present themselves either in a GP's clinic or at a health center or at the casualty department, they will be waiting in the reception area for a while. And unfortunately, we are seeing that a lot of people are getting exposed while waiting to be seen with the doctor, from such cases. So that is the importance, especially for the doctor to pick them up as quickly as possible.
We agree that maintaining a high index of suspicion is essential, is vital in this case. However, given a practical scenario, how should one deal with a case of suspected measles?
No, when someone presents with a rash, I think one of the first things one has to think about is obviously, do they fit the clinical symptoms? That they've had a few days where they were feeling unwell, having a fever, it might be a very low-grade fever, and then the rash appears a few days later. And the rash starts from the head and moves downwards, not from any other place. But then once they see that the clinical features could be related to measles, they obviously have to ask about the vaccination status of the person. Obviously, some wouldn't know. And then they do testing, which in the case of GPs is not always possible, especially the private GPs, and they would need to contact us so we can help them do such testing.
In fact, that brings me on to my next question. What about management in practice, and how does the disease surveillance department get involved in these cases of suspected measles?
So we, as much as possible, encourage, and we have even told patients who present with a rash when they go to a clinic or casualty or the health centers, they speak up immediately. So they'll be flagged at reception. So they won't be kept in the reception area waiting with all the rest, so that risking infecting others. So that is step number one. Step number two, and then the doctor is highlighted and tries to see them, while they've been maybe isolated in another room. Once they have a high index of suspicion that it could be measles, if they are available to them, especially like health centers or casualty, they they take the necessary tests. Now the necessary tests, which is the measles, IgG, IgM, but we require that they take bloods, where you have a purple bottle and a yellow bottle, and 2 buccal swabs. Now the buccal swabs is very important for us, and they have to make sure that when they take the buccal swab, they keep it in the mouth of the person and, swirl it round. It's like a little lollipop. When you put it in your mouth and you're swirling it around the buccal, because it has to be filled with a lot of saliva. Especially in the case of children, they have to be patient, to get a good amount, because otherwise by the time it comes to the lab, they realize they hardly have any saliva and they won't be able to do the test. Where they are stuck, it's important. They phone us, we are on call 24/7, they send the patient back home, and then we will go ourselves to take the tests. And the patient remains at home. He doesn't go to school, doesn't go to work, at least until we confirm the case. If it's a measles, then he has to spend the required time till the rash disappears. And if it's not confirmed, then it could be another rash, and we see when they can, be able to go out again. But it's very important that the patients, because of the high rate of infectivity, that they are kept isolated. Obviously, once we have a confirmed case, we turn to first the immediate family and check their status, because they would have been exposed if they don't have the vaccinations, and many of them we might have to test them as well. And then we open up as well, we go back to the past week from when their symptoms started to how many people they were likely to expose. And we pick up especially the vulnerable groups. Now the vulnerable groups will be anyone who's immunosuppressed, children 1 year of age or less, because they wouldn't have even had the first dose, anyone who hasn't had the measles at all, vaccine, and pregnant women. And these, we are highlighted, and we test them as well, and do any necessary cases, in some cases, depending on the time frame, how quickly we can pick up a case. We might have to give what we call immunoglobulins to the person who's immunocompromised or is a baby less than 1 year, or a pregnant woman, to prevent them from getting any complications. Unfortunately, measles can cause complications, both in the very young and the adults who are contracting these disease. And unfortunately, luckily not in Malta, though, there's always been also a number of deaths. Complications we've had, can be related to pneumonia, encephalitis, meningitis, so they can get serious complications from measles as well. And this is why, for us, we want doctors to take this seriously, and also patients to speak up immediately, because there can be consequences.
And regarding these complications, what are the red flags that healthcare professionals encountering a patient which might have or has measles have to look out for?
Obviously, they will see, while following up the patient who has been confirmed to have measles, you will keep following the patient to see for any other symptoms they might develop, which is symptoms that would indicating they are getting involvement of the organism, the virus, reaching the brain, where you can have meningitis or encephalitis symptoms, or it goes to the lungs, where you can get symptoms then related to pneumonia. So, or like children, very high fever, where it could result in an epileptic fit. So it is important that they monitor them while they are obviously going through the symptoms of the disease.
And when should these patients be referred? When should referral be considered, especially given that measles, as we already discussed, is a condition whereby we try not to expose the patients to waiting areas where they can infect other patients?
No, as much as possible, people are kept isolated at home. Obviously, if there are symptoms worrying that the infection is affecting other organs, and then they would need to go to hospital, it's important that they either contact us, so we arrange how they get to hospital. They have to be pre-warned. The patient doesn't just present himself as a casualty. We contact them before, so they are aware, especially one, if they have to come with an ambulance, and two, the patient won't be kept in the waiting area. He'll be immediately transferred to what we call the decontamination room in the casualty department, and then he will be seen there. The doctors are aware. They will wear any protective clothing if they need to, and and that way we'll make sure that the patient doesn't spend any time in the waiting area.
Thank you very much, Dr. Melilla Fenek, for a very informative and practical practical session, especially in this time where we might be exposed and presented with patients with a condition which we have never encountered before. One final thing, one final message for healthcare professionals.
No, it's important. We try as much as possible, our unit, to send out a quarterly report and even sometimes information leaflets ad hoc, depending on what is happening in the country at the time. So doctors are aware of what is going on in the community related to infectious diseases. So they can be more on the lookout for these infections, and they can contact us whenever they want to so we can guide them and help them to deal with their patients with such diseases.
Thank you very much, Dr. Melilla Fenek. I encourage you colleagues to conclude this e-learning session by completing the set of multiple choice questions associated with this session. Thank you very much and take care.